And the other form of arthritis are non-specific or specific arthritis. These are arthritis when we can't find the etiological agent inside the joint space, inside the synovial. These are arthritis which accompany the rheumatoid arthritis, rheumatic arthritis, inflammations of the joint patients with systemic lupus erythematosus, with ankylosing spondylitis, and so on and so on and so on. Rheumatoid arthritis is the autoimmune systemic disease of the connective tissue, which is characterized by chronic progression. I want to point your attention that it is problem of connective tissue, but not only of the joints. Joints are involvement in the rheumatoid arthritis process, one of the first on the earliest stages, but it is not the disease of the joints, it's disease of a connective tissue. It is not very often problem, it's not very often disease, but still it is enough spread in the world, and you will face sooner or later with these patients with different stages and different forms of the rheumatoid arthritis. It is severe disease, so here you can see a patient with rheumatoid arthritis before the beginning of the disease and few years after. So you see the difference. It is difficult, it is involving all organs, not only joints, but also affects the lungs, affects the cardiovascular system, gastrointestinal, and so on and so on. So it needs to be treated as fast as it is possible. In most cases, the treatment of rheumatoid arthritis is aim of the rheumatologist. But not only rheumatologists are dealing with these patients, and not only rheumatologists must treat them, because it is systemic a process which needs systemic treatment. When we are talking about involvement of the joints in the rheumatoid process, we always mention that it is characterized by proliferation and proliferation changes of synovial membrane and destruction of the articular of the cartilage and periarticular structures. As you remember, synovial membrane is a layer of cells which are placed inside the joint capsula, and it is producing the synovial fluid. It's very important component of the joint, synovial fluid. In the case of rheumatoid arthritis, we have a proliferation of this structure, and the thickness of the synovial membrane in the patients with rheumatoid arthritis sometimes is about few millimeters instead of the layer of cells. Of course, this inflammatory process involves the cartilage. It causes severe destruction of the cartilage of subchondral bone, which is leading to early inability of these patients. Risk factors are unknown for today, so we can mention a lot of risk factors such as viruses, microorganisms, environmental, and so on and so on, which can be noted in patients who are suffering for rheumatoid arthritis. But unfortunately, all these risk factors can be also found in patients who are suffering for other different connective tissue diseases such as psoriasis, for example, ankylosing spondylitis, and so on. So it is not clear how different risk factors are leading for such different diseases. So it is not very clear, and it is believed that a great role in the pathogenesis of all these diseases is playing in genetic components, human susceptibility complexes, different genes inherited, and only with combination with those risk factors it can cause the development of different pathological processes. According to last news, last investigations, it is discussed the role of microchimerism and microbiome in the development of rheumatoid arthritis, the transmission of maternal cells and fetal cells to the child and to the mother, and persistence of this outsider cells in the organism. So such cells with foreign DNA can be found in rheumatoid nodules in patients with rheumatoid arthritis, in patients with systemic sclerodermia, in the areas of changed skin can be also found a great amount of this foreign cells with foreign DNA. So it is discussed how it can result in the development, in the pathogenesis of this rheumatoid arthritis, as well as the role of the microbiome, which explains that not only one germ is responsible for development of the pathological process, but a great role is playing the combination of different microorganisms in the patient, which can lead to the development of the disease. Only combination, not one, but combination of this different risk factors. The joint damage in the case of rheumatoid arthritis is characterized by development of acute and fast synovitis, subchondral bone erosions, and pannus invasion of the cartilage. Synovitis, as you remember, we were talking during the osteoarthritis that synovitis is a fusion in the joint. So there are several types of synovitis. In the case of rheumatoid arthritis, we are talking about proliferative synovitis, not only a fusion, not only a liquid in the joint, but also a proliferated synovial membrane, which is fulfilled all the space in the capsula of the joint. So it is severe synovitis. Besides, in the case of rheumatoid arthritis, synovitis in most cases are developing very fast, so it's fast synovitis. It takes sometimes less than one day to receive a severe synovitis of some joints. In the case of osteoarthritis, synovitis are in most cases slow, so it takes several weeks, sometimes months, to receive some significant synovitis. And in most cases in osteoarthritis, synovitis are characterized by effusion of liquid, and in rheumatoid arthritis, proliferation is always present. Diagnostic criteria of rheumatoid arthritis, I think you know them very well from previous classes of rheumatology. Internal medicine is morning stiffness which is lasting more than 30 minutes, swelling and arthritis of more than 3 or 6 joints, symmetrical swelling of wrist and small joints of the wrist, positive rheumatoid factor, and so on and so on and so on. So what is interesting and you should know, it's our orthopedical classification of stages of rheumatoid arthritis. Of course, rheumatologists have their own classifications of rheumatoid arthritis, with dividing the process for different types, phenotypes, with positive rheumatoid factor, with negative, and so on and so on. In orthopedician, we use Sklerenko's classification, which divides the process into 3 stages, because as you remember, rheumatoid arthritis is a stage disease which can be stopped, and it is developed without adequate treatment, and it is progressed. So the first stage is synovitis. As we told, it can be acute, subacute, and chronic, depending for how many time it is lasting. In most cases, debut of rheumatoid arthritis is acute, and this synovitis is one of the first symptoms which patients will come and show you what they are suffering for. So it's about synovitis effusion in the joint. Sooner or later, depending of the type of rheumatoid arthritis, depending of the treatment and activity of the process, the first stage, synovitis, this exudative synovitis, is changed for the second stage, productive destructive panarthritis. Panarthritis means that not only synovial membrane is involved in the pathological processes, but all the tissues of the cartilage. Panarthritis. The second stage is divided into 3 phases. First is exudative proliferative. When we see the proliferation, significant proliferation of the synovial membrane, it is the second stage, first phase. We mostly use ultrasound for detecting this proliferation of the membrane. It is enough informative. We can measure the thickness, the volume of this proliferation, and what is very important, we also can detect the vascularization. Rheumatoid arthritis synovitis is characterized by high vascularization of proliferated synovial membrane. After that, proliferative destructive stage is changing the first phase of the second stage. First signs of destruction of the joint are appearing on the ultrasound, on the X-ray. In most cases, they are caused by the induction of the panus and synovial membrane inside the joint, inside the cartilage. And the third phase is destructive sclerotic, when the destructive is accompanied by sclerotic processes of all the surrounding tissues. And the last third stage is ankylosis of the bone. Please note this stage, ankylosis. Ankylosis of the joint can be only caused by inflammatory process. Degenerative dystrophic diseases such as osteoarthritis are never leading to ankylosing. Ankylosing is always the result of inflammation. Specific, non-specific, acute, chronic, doesn't matter, but ankylosis is always the result of inflammation. 2 types of ankylosis we divide, fibrotic and bony ankylosis. What is different and what is ankylosis at all? When 2 bones grows together, it is ankylosis. It is completely absence of movement in the joint. Completely absence of movement. If this is accompanied with pain, it is fibrotic ankylosis. Bony ankylosis is painless. Systemic presentation of the rheumatoid arthritis as well, I think, is well known by you about different types of vasculitis, osteoporosis, keratoconjunctivitis, and so on. Please note about keratoconjunctivitis and the eye changes in patients with systemic diseases of the connective tissue. Often it is the only one problems which our patients are suffering for a long time. I have had a patient in my practice who were treating for about half year in ophthalmologist because of keratoconjunctivitis. They were treating without result. The patient was losing their eyes. They were trying nothing. There were no other clinical signs of rheumatoid arthritis except this keratoconjunctivitis. And only after that somebody recommended to perform the screening for connective tissue diseases, and they found the positive rheumatoid factor, positive anti-nuclear antibodies. So it was the debut of rheumatoid arthritis, which was only about keratoconjunctivitis. Clinical presentations, loss of weight. A lot of these patients are depressed because they are suffering for a long time with symptoms, with pain in joints, with swelling of the joints. They are depressed because they must take a lot of drugs, they are inability, they have a rise of temperature, and so on and so on. And of course, patients have different types of presentations. It can be acute, when the patients feel the symptoms during very short periods they are developing, and chronic, for example, when they are developing several weeks or several months. Very popular, it is so-called rheumatoid hand. It's a visit card of patients. You can read about these deformations, typical deformations of hands in patients with rheumatoid arthritis. But you should remember that these deformations are not about the early stages. It is deformations which are developing during years of the disease. Sometimes when the activity of disease is not very acute, sometimes patients are suffering from these deformations and they even don't know they have rheumatoid arthritis. But in most cases you will see these deformations in patients with very long history of disease. The deformations of fingers are very typical, and they are caused by destruction of the small joints of the wrist, and besides it is a result of problems with luxation of the tendons of the muscle, tendons of the wrist. This luxation of the typical place, which is called by chronic inflammation of these tendons, is resulting in typical deformations, such called swan neck, boutonniere, or mallet finger. So all this about destruction of small joints of the wrist, fingers, and subluxation and luxation of the ligaments from the normal position of the hand. Here you see the synovitis of the knee and how it can be measured using a simple ruler. You see the right and the left knee. What is the difference? The left knee is completely swelled. We see the significant effusion in the knee, and we can measure, compare both sides using such ruler. It is more than 10 centimeters difference. And that's how the hands of patients are looking like. They are swelled, they are warm, the fingers are deformed, and when you perform a palpating, the hands are often wet because of higher temperature in the place of inflammation, and the skin is looking very thin. You will test it by your palpation. The same situation with legs when the big joints are involved in the process. Not only fingers are involved, big joints are also suffering. You see, this deformation is called the deformation of blowing wind, the deformation of the knee joints, the varus deformation of the right hand, right leg, and valgus deformation of the left leg, so blowing wing deformation. Blood test. Blood tests are widely used to determine the rheumatoid arthritis process and to set the diagnosis, to perform the differential diagnosis with other diseases. Traditionally, we perform general blood test with erythrocyte sedimentation, leukocytosis, and rheumatoid factors and C-reactive protein. Unfortunately, rheumatoid factor has a limited value because some healthy patients after 60 years old, a lot of patients have positive rheumatoid factor for normal. Besides, there are a lot of patients with negative rheumatoid factors who have rheumatoid arthritis, so-called seronegative rheumatoid arthritis. That's why we prefer to use more modern method of testing. It's detection of antibodies against citrullinated protein or mutated citrullinated vimentin. Comparing for rheumatoid factor traditional, they have more sensitivity and specificity, which is about 95-99%. So, C-reactive protein is a routine method of diagnosing not only the presentation of inflammation but also the activity of inflammation. It can be used to evaluate the efficacy of your treatment. As I told you, ultrasound is widely used for diagnosis of synovitis and proliferating of synovial membrane in patients with rheumatoid arthritis. Don't forget, when you will be perform the ultrasound for this patient, don't forget to measure the blood flow in the changed synovial membrane. X-ray. X-ray have specific features for patients with rheumatoid arthritis, but first signs of which are characterized for rheumatoid arthritis appears no sooner than after 2 or 3 weeks after the debut of rheumatoid arthritis. First of all, they are appearing nearby the small joints of the hand. It's this so-called extra-articular osteoporosis of the bones nearby the small joints. So, but as I told you, it takes about 2 or 3 weeks to see these changes on the X-ray. Sooner it is very poor that you will see some changes on X-ray. That's why we use ultrasound widely in early stages, because it can show us effusion, it can show us inflammation in ligaments, inflammation in joints, in tendons, and it can show us the effusion of the joints. And that is how rheumatoid arthritis is compared to osteoarthritis is looking like. Please note that even in the case of severe osteoarthritis, just like here, you will see not such pictures as in rheumatoid arthritis, releases of the articular ends and developing of the ankylosing. Of course, rheumatoid arthritis can cause the luxation and subluxation of the joints, just like here, but you see no signs of dysplasia of the hip joint. So it is pathological luxation because of inflammation inside the joint, chronic inflammation. You see the absence of the femoral head. The femoral head is undergoes the lysis of this part because of chronic active inflammation. And osteoarthrosis. You see, you will never receive such a picture in the osteoarthrosis, even in the most severe stages. And that's how the ankylosis is looking like. You see the completely lost of articular space, joint space, and we see the two bones are growing together. So bony trabeculas are throwing from one bone to the other. Just like here, you see the completely absence, protruding coccytis, lysis of the femoral heads, formation of multiple cysts, and two bones, pelvic and the hip, are growing one to the other. Just like here, it is very significant. It's bony ankylosis. You see that these lines, trabecular lines, are going uninterrupted from the femoral bone to the pelvic. So you see this result of ankylosis, completely absence of movements in these joints. And when you see this in science, when you see such picture on X-ray, it's for sure the result of inflammation. Maybe it was septic inflammation, maybe it was aseptic inflammation, but it's always result of inflammation, not degenerative dystrophic process. MRI, so soft tissues can be evaluated on MRI, changes of soft tissues in the case of rheumatoid arthritis. For example, it is a patient with rheumatoid arthritis and so-called Baker's cyst, giant Baker's cyst. It in the area of the posterior knee joint. This Baker's cyst is causing the compression, can cause the compression of neurovascular structures which are following in this region, and they must to be released. This cyst must to be incised. So you can evaluate the volume of the effusion. This white spot is a liquid inside the hip joint, as well as this spot is the liquid of the Baker's cyst. What is the aims of treatment is of rheumatoid arthritis from the point of view of the traumatologist is to keep inflammatory process at minimum or completely kill the inflammation, and to preserve from the deformities, and to save the movements in the joint, to save the joints for patients, to avoid the inability of the patients. I will not focus your attention about systemic treatment of the rheumatoid arthritis. I think you are talking about this on rheumatologists. I will tell you much more more interests about systemic treatment of patients with rheumatoid arthritis. I'm sorry. I will tell you a few words about orthopedical treatment. The same non-steroids are used, the same you remember that we must change non-steroids for better result in patients. Methotrexate and other cytotoxic drugs, immunosuppressive, are used. Corticosteroids are widely used, not only systemic but also local injections of steroids, and surgical procedures. In early stages of rheumatoid arthritis, when we talk about first stage, when we talk about synovitis, we can perform the removement of synovial membrane, proliferated synovial membrane, which is looking just like that. You will never see such a picture in patients with osteoarthritis. As you remember, I show you the picture how the joint is looking in the patients with osteoarthritis. So you can compare the difference. You will never see such proliferation of synovial membrane as it is here, and here it is what we call panus, soft tissue, vascularized soft tissue, which is covering the surface of the cartilage completely, and this panus is penetrating the cartilage and causing its destruction. Video is not working. I don't know why this video is not working. I put the videos in a fold. You will have a chance to look it after our lecture, because I don't know why they are not playing here. And here is how we remove the panus, which was covering the surface of the cartilage, and you see such wormholes where the cartilage was penetrating where the panus was penetrating the cartilage, so damaged cartilage completely. By the way, you remember that I told you that healthy cartilage has no vascularization, so please notice how the panus is looking like vascularized, completely vascularized. So the same view, the same patient, the result of the remove of the panus, and you see how the cartilage under the panus is looking like such wormholes, destructed cartilage, and there is the place where this panus appears from. It is here we have femoral condyle, and here we have a plateau of the tibia. So the place where the cartilage is attached is changed for the bony tissue. So here, from this place, the panus began its growing over the cartilage. There's another view, so you see this moon landscape of the cartilage destructed by rheumatoid process. And here is the video how the panus is removed. Immunobiology, I think you know about this method of treatment for rheumatoid arthritis. It's modern treatment, immunobiological medicine, which allows to kill the activity of the process and allows to receive a good result of the control of the disease. But still, if we have such proliferation of the synovial membrane, it will be not regress of this process. So we have zero activity of the rheumatoid process, but still we have a great amount of changed synovial membrane in the joint. The same patient, a giant, all this is a giant Baker cyst, you see here, which is causing the compression of the neurovascular structures in the posterior region of the knee. It's classic synovitis, how it is looking like in the case of rheumatoid arthritis, and it is how the synovitis is looking like after the treatment of biological agents. So you see no vascularization, no activity, no blood vessels. It's pale, completely pale, but still it is a very, very big amount of changed synovial membrane inside the joint, which must be removed surgically. So maybe this video will start. No, this video is not starting as well. So removal of synovial membrane, and we see the defect of the cartilage under this panus. Again, synovial membrane, and again video is not working. And this is Baker cyst, which was removed in this patient from the popliteal, from the knee area, posterior wall of the knee. So you see the giant Baker cyst which was removed, and this Baker cyst was causing the compression of the neurovascular structure. So you see the nerve which is crossing here, and this Baker cyst was compressing and causing the chronic pain and neurological symptomatic. So you can perform punction of the Baker cyst to evacuate the fluid from it, and it will lead a patient for a short period to feel better. But in the case of such giant Baker cysts, the function of them are not sufficient. We are going to make a surgery, open excision, and a removal of this cyst. And this is elbow completely damaged. You see the completely damage of the bones by the rheumatoid process after the synovial membrane was removed. It is more historically operations. We don't use such surgeries anymore, open surgery in the rheumatoid arthritis. We prefer to use arthroscopical techniques because it gives us more better results, and the patients are rehabilitated more easier and faster. But still, it was done historically. You see the complete absence of the cartilage, which is covering the elbow joint. And again, in the case of severe damage of the cartilage after rheumatoid arthritis, the only way we can help patients is to put them in artificial joints, to perform endoprothesis of the joints. We can use hip endoprothesis, knee endoprothesis. All joints can be removed if they are damaged. As well, in the case in the osteoarthritis, we receive very good result of this surgery. Patients can walk without additional crutches, and they feel much more better than before the surgery. The same situation, the knee joint is replaced by the artificial joint, damaged knee joint. As you see, severe deformation, varus deformation, which was corrected during the surgery. So the axis of the leg is restored, and the position of the knee joint, artificial knee, is very nice. So we use a special devices to restore this axis of the limb. Thank you for attention. If you have questions,